So I'm a dinosaur. I'm a neurosurgeon. Whenever anybody thinks about healthcare, they don't think about neurosurgery. They don't want it. They don't think of it. Let me give you some numbers. When I started in neurosurgery, there were 4,500 neurosurgeons in this country. About maybe 7,000 in the world, and about half or more were doing intracranial surgery, which means on the brain. Today, there are 3,900 neurosurgeons in the United States, and fewer than 1/3 are doing surgery on the brain. What that means is there's a tremendous dearth of neurosurgeons covering emergency rooms. What that means is that emergency rooms have had to consolidate. And there are many places, Wyoming, for example, pretty wealthy state, lots of oil, where the question when it comes to somebody with head trauma coming into the emergency room is not can we take care of it, but is the weather going to be good enough in Colorado to be able to get a life flight into Colorado across the mountains and to land safely in a place where somebody can take care of him. There's another question. How do we know that this patient should be transferred? There's another patient. There's another question. How do you monitor that patient while in flight? There's another question, which is, are there cases in which you want to decide that you really shouldn't transfer somebody because the outcome isn't going to be good enough? And you may think that that is a ridiculous, ridiculous question. Three things I'd like to say about that. One, a number of years ago, the gold medal for ethics at the Uniformed Services University of the Health Sciences was not how you take care of patients who are injured in war, but whom should you not treat. Number two, one of Mr. Obama's first questions when he came into office was, should we continue providing health care for soldiers? Because they're volunteers, and maybe they should pay. Maybe we don't have an obligation to take care of them. Number three, one of the major issues today in medicine, which is the management of stroke, asks the question not what is survival, but what is outcome? And is there a point at which the outcome is insufficient to justify intervention, particularly if the intervention is expensive or complicated, or it involves resources that people don't ordinarily have? So I think of healthcare maybe differently than a lot of other people think about it. Most people think of good healthcare in terms of access, in terms of the diffusion of healthcare, in terms of prevention, and I think that all of those are really important things. But I would also ask another question, which is part of what I want to talk about. And that is, what do we do? What should we do? What can we do? And to bring this into a very, very granular framework, what is Massachusetts? Massachusetts is some of the best health care in the world, forget the country. And I say that with great pride, but I also say that with great humility, because we have to ask the question, what is it that we do that is good? Is it sustainable? Is it affordable? So sustainability means something different in medicine than it does in other forms of economics, because there's also a moral imperative. And one of the things that I'm going to talk about is Galbraith's Good Society. What is the place of health care in Massachusetts, and what should we be doing? So here's the vision. Health care, ideal health care. Number one, no one left unwell. Number two, no one left untreated. Number three, very important, everyone treated well, which is entirely different premise. Then health, longevity, independence, and well-being. We don't want to cure. That's what we want. That's the outcome that we want. Economic sustainability, and then something which is very human. We want privacy and we want confidentiality. We want choice in whom we go to, and we want compassion, because there's a balance. Everybody who is sick is in some sense infantilized, and everybody who's sick wants to be taken care of and wants to know that what they're going to be given suits them individually. This is the Pont Neuf in Paris. It was the height of technology in the 16th century, and one of the reasons it was built this way in front of Notre Dame was so that you had a broad area where people could come and exercise and play, and where people wouldn't be crowded. It was one of the places in medieval, late medieval, early Renaissance Paris, where the king said, we will use technology to make a wide bridge. And the other thing about it was that the bridge was supported on the island as well as on both banks, and that let it be a firmer bridge. It's a very interesting metaphor for technology, and remarkably close to the Hippocratic vision that said we don't traffic in medicine as a cure. What we really want to do is to create an environment in which health can be preserved. And that brings up the fundamental questions that I started with: what can we do and what should we do? So think about the activities of healthcare. Try breaking it down. What have you got? You've got health, longevity, prevention. Those are three things before somebody gets sick. The next thing you have is diagnosis. What's wrong? It's a heuristic. The next is prognosis. What can I expect? Why does that matter? Because in the realistic world of healthcare, knowing that there are risks to taking care of people, and knowing that there is no such thing as a magic wand or the Star Trek machine that I press the button and now you're well, there are risks to care. And the question is, are there points at which the risks of care balance or unbalance the risk of disease? Then therapeutics. What do we do? What medicines? And we could add surgery to that as well. I would. Then we're interested in recovery. How do you help people recover? Do you send a woman home 2 days after she delivers? That may be economically worthwhile. Do you send somebody with a ruptured disc home after 2 days? You can, but what does that mean in terms of the rest of the economy? What's the supposition in terms of who's going to be taking care of those two people at home? Just because you can do something doesn't necessarily mean it's a good idea. And that gets to the next question, the question of quality of life. How do we assure quality of life as well as recovery? So there's a very interesting set of questions around amputation after the horrible injuries that have occurred in Iraq and the horrible injuries that have occurred in Afghanistan. There's an argument. Do you save a limb knowing that it's going to be painful and difficult to use, or do you replace it bionically with a prosthesis? Across the street at MIT, you've got some fantastic prostheses. Is that better, or is it better to save the limb? And then this thing I keep on coming back to, which is care and compassion, which is ultimately what patients judge physicians about. They judge the care that they get not only technically, but they also judge it by the care that they get. Who is healthcare? Everybody in this room is a patient, has been or will be, I promise you that. Then you have physicians. They're also patients. And there's a wonderful idea that says, you know, if you're a physician, learn to think like a physician, but to feel like a patient. Then there are delivery networks. Maybe they're hospitals, maybe they're clinics, maybe they're offices. You have researchers and innovators, not the same. Researchers traffic in information, innovators traffic in change. You'd think one goes to the other, but it's not automatic. Biopharma, big in Massachusetts, huge in fact. Medical device industry, huge in Massachusetts. Medical informatics, huge in Massachusetts. Charities and trust, maybe not so much in Massachusetts, but it doesn't matter. The effects are here. And then the rest of the bioeconomy. And the rest of the bioeconomy is everybody who works around healthcare and cares a lot about what's being funded, what's being done, what the results are. And the interesting question is, what do people worry about? This is probably too small to see, and I don't plan to read each one of these lines, but let me read a couple. This is from Drew Altman, who's the head of the Kaiser Family Foundation, that on a regular basis pulls together opinion polls by patients of what they worry about. Number one, premium costs, and this is important, the share of premiums they pay if they have employer coverage. So it's not only the absolute number, but a sense of fairness. Deductibles and other forms of cost sharing. Drug costs, especially for the chronically ill. I don't know whether you've seen recently that insulin prices have gone up hugely. How do you deal with that? Whether the insurance covers the services not that they need today, but they will think they might need. So somebody's father had a heart attack at age 68. If I need it, will I be covered? Remember, I'm on Medicare. I'm probably no longer working. Whether they can go to the doctor or hospital they want. Do you know how hospitals used to be chosen? They used to be chosen by women on the basis of where they delivered. If they had good care, that's where all the care went. If they had bad care, they went someplace else. With the internet and with the diffusion of information, other criteria have come to light. You know what the second most important thing is about how hospitals are chosen? The size of the parking lot and the convenience to get from the parking lot to the hospital. And the third thing is the walkway covered in the winter, or do you have to worry about whether you're going to fall on the way to the hospital? And the fourth thing, waiting time in the emergency room. Okay? These are not quality measures, or are they quality measures? Are they in fact talking about something we very rarely talk about, which is the service model in healthcare as well as the delivery model? How well is healthcare actually delivered? So if somebody comes over to you and says, Sarah, would you please come with me? And you've never met me before, you might not like that. You might say, you know, I have a name. Don't call me by my first name. I'm not in 4th grade and you're not my kindergarten teacher. Call me by my name or by my title. You know, excellency might be very good for you. There are nice titles that you can call people. But we don't do that because we have reduced many aspects of healthcare to a question of friendliness. And if they say, why am I calling you Sarah? It's because of HIPAA, because of privacy. And if I have to say your name in public, I don't want to say your last name. Is that really what we want to do? Then there's another question, the hassle and red tape in healthcare and health insurance. How many people have used health insurance in this room? I have. What's the likelihood that the bill you're going to get is right? You know, is it asymptotic to 0 or is it 0? In any case, it's just not likely that that's going to happen. And then 2 other things stand out. The first is that seniors care a lot about Medicare and sometimes will vote purely on a Medicare issue. What is the fear? Medicare, like Social Security, running out of money and taking care of the security, removing the security around healthcare. And Americans don't care overall as much as experts do about improving healthcare and removing unnecessary care. Now this is 2015. I don't know that it's changed, but there was something very similar in 2007. And so one of the things you can say about healthcare is whatever else, if you want to predict what's going to happen, it's going to be some kind of parallel of what's happened before. And I suspect that these concerns are not going to go away. So American Journal of Medicine, 2007, 10 years ago. What do people worry about? 62% of all personal bankruptcies in the US are related to medical bills. 78% of those involved had health care insurance, but went bankrupt because of gaps. Average family of 4 spends about $20,728 per year on health care, which is 7 times what the cost of gasoline was at that point. 75% of all expenditures go towards preventable chronic disease. Healthcare Insurance Administration expenses in the United States are 8% of all US healthcare, as opposed to Finland when they're 2%. Huge difference. And Finland has better and broader health insurance than we do. Before the Affordable Care Act was passed, premiums were rising very quickly, unsustainably, unaffordably. You know what's happened subsequently? They're rising unaffordably and unsustainably. And discounting subsidies, the trend continues constantly. And my favorite is that the ambulance industry in the United States makes more than the movie industry. Yep. Well, that's what they say. That's what they say. That's what I've been able to find. So we have a balancing act. And the balancing act for the future is access as opposed to choice. What would you rather have a society? Knowledge that you're going to get health care but you don't get to choose? That's the military model. That's the VA model. Or would you rather have the choice and maybe not have quite as easy access? The second thing is cost as opposed to affordability. Would you rather have, irrespective of cost, the best care, or would you rather have affordable care? Care and caring. So everybody talks about, and I'm a huge proponent of telemedicine. I was one of the people who founded Teledoc, which went public on the basis of its ability to deliver remote care. But is that what everybody wants? And quality and outcome. And there are two kinds of quality, quality of care and other expressions of quality. So this is one of my favorite phenomena. Does everybody know the coin called the guinea? It's an English coin. This happens to be the coin from the time of George III, the Revolution in America. Guineas are a pound and a shilling. They're no longer used. They're obsolete. Went obsolete in 1970 when Britain went to the decimal system. But it's used still for two things, healthcare and antiques. And the reason is that you don't want to show that you care about costs. You want it in a different denomination. And in the United States, for many years, that's exactly what happened. But the problem is we can't afford to do that anymore. The guinea is dead. By the way, it's called the guinea because the gold mines from which they were struck were in Guinea and Africa. So what would no compromise healthcare look like? Let's just project. Let's just model it. Just completely change your ideas about what healthcare is about. First of all, what we want is access to care which is not geographically restricted. I want to find the best doctor for doing any procedure I want or for doing any diagnostic I want, any place in the world, and I want that person to be licensed and be able to practice any place on the basis of a standard licensing examination. In order to do that, I need two things. I need the technology to be able to do something. Already exists in stroke, because the model for stroke care in this country increasingly is a stroke center with a remote physician with details which are projected on a screen with a clinical record, with a CAT scan or an MRI, and the decision of where to bring the patient can be made remotely. It can be done. Can it be done for everything? Well, if you think of an electronic stethoscope, if you think of x-rays, almost everything can be done electronically or telemetrically today. Maybe not everything. You can't deliver a baby telemetrically, but in certain universities, particularly in the Midwest, close to the Canadian border where you have huge rural areas, residents are trained in how to help physician extenders do things like deliver a baby, like on a Navy ship, do an operation. There's a talent to doing that. Train people how to do that. The next thing is cost mitigation. We cannot rely on guineas to talk about health care. We can't say, oh, this is too expensive, make it cheaper. The question is operationally, what do we do to make a difference? Well, there are a few things we can do. One of them is to think in terms of economies of scale. For many years, there was a hospital outside of Toronto that did hernias when it was very difficult to do hernias. That's all they did. They had better results than anybody else. They were cheaper than anybody else. They had fewer recurrences than everybody else. And it had to do with the combination of volume and quality and method and record keeping and accountability. Are those the only things that matter? No, but it's a very, very good start. And what that goes along with is specialized centers. Should every hospital do heart surgery? No. Can you tell what hospitals should do heart surgery? Is it a question of the hospital or is it the question of the staff? Well, we don't let every hospital do transplants, and the reason is it doesn't make sense. You need facilities and you need volume, and there's a standard of care. We don't let every hospital do neurosurgery. Most of it is self-regulated. Very little of it is imposed. It doesn't have to be imposed. Ultimately, if you create a standard for output, a standard for outcome, then you can also get a standard for quality. The next thing is safety. And if I had to say what is terribly important from my perspective, it's patient safety. I'm the chairman of the Council on Surgical and Perioperative Safety, which is a nationwide group that is working on surgical safety and part of the Patient Safety Foundation. And it turns out that preventable error, preventable physician error, is a huge problem. I went in just a couple of weeks ago to have a vaccination for some travel I needed to do, and there I was, supposedly informed, supposedly aware, supposedly engaged, and I got the wrong medication. It happens all the time. Was it anybody's, quote, fault? No, it really wasn't. It was one of those things. Was it preventable? Yeah, it really was. By one conversation prior to the giving of the medication. What happened was I was told what the medication that I was injected with was after I was injected, whereas it should have been done before. It's method. But if you could have a massive error reduction, that, as much as anything else, and maybe even more than anything else, would reduce the cost of health care, prevent readmission, have patients feel that they're getting better quality, and really result in a better quality of care. And errors are surgical errors, wrong site, wrong side, wrong patient, wrong operation. It has to do with medication errors. It has to do with discharge instructions. You know, it's absolutely wonderful. You take somebody in her 70s who's, you know, high school educated, smart, worked all her life, and then you start talking to her in medical language when she's about to leave and tell her what she is and not supposed to do. That's absolutely useless. It's not communication. So one of the little things that could make a difference in terms of technology, this is not a high technology, but it's important, is to give a recording on a credit card that lets you hear the instructions. And they can be repeated again and again and again, to be listened to by whomever she trusts, not only the nurse. And the follow-up. The follow-up, does it have to be a doctor? No. Does it have to be a nurse? No. In many places, it can be a well-meaning, kind person with a certain level of education and compassion who asks a simple question. How are you? And you'd be surprised how much information comes from asking, how are you? Because people will tell you if they think you want to know. We need to encourage that. The next thing is personalized care. So personalized care says, look, you have a genetic likelihood, you have evidence of sensitivity to a certain medication. These exist, they're not generally done, sensitivities are generally minor. However, the ability to track these sensitivities across populations is very, very important. Native Americans, for example, are known to have certain enzyme changes, differences from other people. And that's why the sensitivity to alcohol was something that was very much exploited by early settlers in the United States, because they were more easily inebriated than people who didn't have that enzyme deficiency. We can tell what people have, and we need to work with it. And medications need to be developed more on safety as much as on efficacy, and to look at populations. What population works? The next thing is analytics. We talked about analytics in other discussions today. Analytics have to do with not only grabbing information, but actually using it. What we do is descriptive analytics. What do people do? We have some predictive analytics that are very, very good. We know that if somebody has the following set of events, they're likely to have other events. What we don't do is prescriptive analytics that say, if you see this pattern, think about doing something else. We do it in industry, we do it in aviation, we do it in the navies, we don't do it in medicine. And that's one of the things that we ought to be seeing. We ought to be thinking in terms of effectiveness and efficiency. Efficiency is what you get for your money, and effectiveness is, are you getting what you think you're getting, and deciding what it is that you're getting. And then quality of care. Outcomes, the amount of time it takes. I'm going to again add compassion and the moral dimension of care as part of what we do. Technology requires not only things like the kinds of technology that we all talk about, computers, data storage, access, privacy, and things like that, but also new teaching paradigms. And new teaching paradigms that say not only are you responsible for the care of the patient, you're also responsible for learning about and thinking about how you prevent error, how you save money, what your choices are, and how to bring them in. And those are increasingly important research paradigms. And on the subject of research and innovation. In Massachusetts, we are a research economy as well as a caring economy. It would be a terrible mistake from my perspective, in my opinion, to stop underwriting research, even if we realize that what we want as research is not always going to be productive in terms of a product. We need to allow for mistakes in research or pathways that are blind. And separately, we ought to also encourage and train people for translational research, the purpose of which is to create a product. And technology in healthcare is something that we can shape. We can shape technology. Ways in which technology is used have to be in a social context. We want technology in order to give better patient care, in order to have better outcomes. And we have to talk about what we want to accomplish. Do you really want to have fewer readmissions into hospitals? That's great. Prevent errors, track people, make sure they don't fall between the tracks. Technology in healthcare will succeed the same way it will in any other place. Define what is best, figure out who sets the criteria, and figure out who is included and excluded from the discussion. And my view is that in terms of healthcare in particular, we need to understand there's more than one path, and we need to have the outcomes to define not only what we have accomplished, but the way in which we accomplish it. Are these things realistic and desirable? Yeah, I think so. I think it depends on our priorities, and the healthcare is also a marker for a good society. So if you look at healthy societies, you will find that they're also better societies in many ways. And healthcare disparities and inequalities are very important markers for failed society. So just to summarize, a number of things. One, we need to think about prevention, not only in terms of vaccinations, but in terms of things like environmental health, in which we can have populations healthier because of the environment in which they live. We need to think about vulnerabilities which are genetic, so that we can save people from drug-drug interactions and from other interventions which might not be safe for them. We have to work on the issue of compliance. One of the main problems is people not taking medications, anti-hypertension medications, other medications, which if they took would render them healthier and reduce the cost of healthcare to society. We've spoken about error. I think we understand that. Access. Don't think of access only in terms of going across the street to the practitioner. How else, what other models are there that can reduce the cost of access, increase the convenience, and make it possible for people to have health care even when they can't easily travel? Medical records. Right now, the problem of the electronic health record is the amount of time it puts on the physician. It can take 2 or 3 hours a day extra for electronic medical records to be filled in. Unaffordable. Cannot do it. You wouldn't ask a patient to spend 3 more hours a day in a doctor's office. Don't ask a physician to spend that. How do you do that? Number one, don't think only in terms of keyboard entry. Think also in terms of dictation. That's the way doctors are used to working. Number two, think not only in terms of defined fields when you're talking about a medical record. Think about the analytics that let you use words and phrases in order to search and in order to organize. Number three, think very carefully about the codes that are used for billing. The codes that now use are often laughed at because they include things like the diagnosis of being bitten on the arm by an orca whale. It's true that they are absolutely completely detailed and probably terribly, terribly comprehensive, but they don't necessarily work for the physician. And technology needs to make things better, not make things worse. We need to have our training and our continuing training for physicians and for healthcare providers built into the technology. We need to think about data, not in terms of the data that we get, but what to do with the data. And to figure out, for example, when you find out that a medical test has only an 85% chance of giving you the right result, why are we using the word only? Is that enough? Is that not enough? What do you do if you're somebody in the 15%? What privileges do you have? Can you disagree with what a test says? Can you ask to be tested again? We need to think about 2 kinds of research. One kind of research is translational for a product, for a purpose, and the other is what I would call hypothesis generating as well as hypothesis testing. It lets you look at what's coming and try to find a better way of doing things. These are the ideals of a perfect society and perfect health care. Will it come to pass? A lot of it, yes. All of it, probably not. We have to be willing to invest not only in the science, but also in the care. And the technology that we have and the technology that we involve is technology that enable these things to happen. Above all, the important thing is to make sure that technology produces time for the caretaker and the patient and allows the human aspect of medicine to continue and to strengthen. What do you think?
It's a great presentation. You spoke a lot about the provider side of the equation. Can you speak, given the time limit, a little bit to the payer and
Sure.
sort of the pharma and equipment provider side of the
Sure.
equation?
There's a lot to be said. Payers have interests which are not necessarily the same as providers or doctors or institutions. And the reason I brought in that slide to begin with is to realize, to acknowledge that there are many stakeholders. This is a polyhedral. And there are many different planes on which people work. So providers need information. The payers need information, but they may be for different reasons. What the payers want is to often enforce a kind of economy, and what the providers want is to provide a definition of best care. So, you know, for providers, it may be, I want all the information I need to get every test possible on my patient. And for the provider, the answer is I need the least amount of technology applied to the patient to get the best possible outcome. So it's unfortunately a slightly different optimization curve. There are ways of dealing with it. One of the ways that we're dealing with it is not part of this discussion, but tort reform is absolutely necessary in this country because the rules for physician accountability and what their responsibility are do not accord with other things that we're doing in society. So it used to be, for a quick example, that a physician would be, a surgeon would have to take out a certain number of normal appendices to show that he or she was taking out all of the diseased appendices that were there. And that was the way you defined a good physician. We don't do that anymore, and the payers won't pay for it anymore. So we need to have a discussion that actually includes both sides of the equation. What is acceptable? What are the legal structures that allow physicians to practice with a certain amount of clinical judgment? What will the payers pay for? And we also need to realize that many payers are also providers. And many payers also have other interests having to do with profitability and shareholder interests that need to be included in the equation. I don't know how to do that exactly. I don't know what to do when healthcare costs rise because real estate returns drop for insurance companies. And I don't know if that's going on today, but it's certainly gone on historically in the past. I think each of the stakeholders has a perspective. One way of reducing the cost of drugs is by applying certain technologies, not only to the drugs, but also to the regulatory path, so that patient safety in clinical trials can be done more efficiently, thereby reducing the costs of failures associated with the initiation of new drugs. It's another discussion, but the thing is to ask the question, what can we change in order to achieve certain outcomes? Outcome number one, patient safety. Outcome number two, access to treatment. Outcome number three is reduction in the cost of delivering technology. And that's where I think it's going to make a difference. We have to speak explicitly to those issues.
Thank you.
Thank you very, very much.